much about medicine is about our engagement with our patients, being able to hold a patient's hand or give a patient a hug. And it brings tears to my eyes to now think about situations where I haven't been able to do that, or I've had to say goodbye to patients over the phone.
People are really afraid of this, and what do I do if I get sick? So we've actually developed a COVID care clinic where a nurse will call you every day. It's a specialized cancer nurse, monitor symptoms, and make sure that they don't need more urgent help.
Don't delay treatment. Cancer doesn't wait for COVID. So, the earlier that we get things detected and treated, the earlier and the better the outcomes will be.
From the Zoomerplex in historic Liberty Village, the Zoomer with Libby Znaimer.
Welcome to the Zoomer. I'm Libby Znaimer. This year, 25 Canadians will be diagnosed with cancer every hour. COVID hasn't changed any of that. What the pandemic has done is disrupt the spectrum of cancer care, delaying diagnoses and treatment and halting clinical trials. How have healthcare systems been reorganizing cancer services to ensure that patients continue to receive essential care while minimizing exposure to COVID? We'll ask that of our expert panel. But first, let's tee up the topic.
Cancer doesn't wait. But patients across Canada have had to because of COVID-19. Screenings fell sharply. Across Canada, hundreds of thousands of CT and MRI scans, often used to screen and diagnose potential cancers, were delayed. In Ontario, mammograms decreased by 97%, Pap tests by 88%, and FITS, which screens for colon cancer, by 73%. Treatments were also impacted. In a recent survey, 54% report having had a cancer care appointment cancelled, postponed, or rescheduled. And according to one Toronto oncologist, there's been a 25 to 50% drop in cancer surgeries. In Canada, an average of 617 people are diagnosed with a form of cancer every day. With widespread delays and cancellations, the full scope of COVID's impact on their survival rate is still unknown.
One of the big keys to surviving cancer is an early diagnosis. Yet it seems most of the delays are on that end of the process. In addition to postponed regular screenings, the Canadian Medical Association says CT scans and MRIs have been delayed by 1 or 2 months on average because of the pandemic. How important are these tests, and what is the impact of postponing them? Let us start with Dr. Gill.
In the context of delays in diagnosis, as a medical oncologist, we have spent a lifetime of trying to improve cancer awareness and encourage patients to get screened and recognize symptoms early. And the pandemic has presented this challenge where for all medical conditions, and certainly for cancer, people are hesitant to go into hospitals, to go into emergencies, to present with symptoms. And certainly I've seen this in my practice in recent months where even patients with symptoms have delayed medical assistance. From a screening perspective, I think this is, we are still learning, and we will continue to learn what the downstream consequences are and have been of delays in diagnoses and deferred cancer diagnoses. I think we all recognize that an earlier diagnosis is associated with a better outcome. And we have evidence that does suggest that delays in diagnoses are going to have negative impacts on patients' outcomes. To date, we've had almost 12,000 COVID-related deaths in Canada. This is a real problem, and the pandemic is not to be minimized. But as you said earlier, cancer is still here. And every year, over 84,000 Canadians die of cancer. That's 7,000 deaths per month. So we are living in a new normal, but cancer is still the same big problem.
Dr. Lael, what's your view?
Thanks, Libby. Thanks for having me here. So what we've been seeing at the Cancer Centre, certainly at the Princess Margaret, is a reduction in the number of people with newly diagnosed cancer coming through the system. And so it'll be really great to hear from Dr. Larson about how we can encourage people to really see their family doctors or primary care practitioners to have their symptoms looked at, to get checked out, to get that initial diagnosis. We've been able to recover a great deal of ground that was initially lost because of delays. So, we're really catching up in terms of cancer surgery lists. We were able to prioritize those, and we've really worked hard across the country to really help patients modify their cancer care. So, for example, if your surgery got delayed, we looked into whether curative radiation was an alternative in lung cancer, for example, or if normally you would get surgery and then drug therapy afterwards, we've tried to reverse it. So we've worked really hard to make sure that people haven't had a compromise of their care, but still really tailoring it to make sure that we do it as safely as possible.
Dr. Larson?
Thank you, Libby. Yeah, it's a very complicated space. I'm a family doctor working at Women's College Hospital, and we run into this every single day in our practices. Because remember, for patients, the idea about cancer starts well before the diagnosis. Is with that first worry, that first suspicion. So that first wait is an issue. Getting to see me, getting to see my colleagues, that's sped up now a little bit as we're introducing more of the virtual care tools in our practices. Not everything has to be examined. Some things can move directly to other interventions, but also focusing on how to get people in for the right examination at the right time is my first step. Then from there, we have to decide screening is one thing, but diagnosis is another. So getting people for the tests that are required, again, far more complicated than it used to be. Things are improving, at least in Toronto, where we have now more availability, more access, and the surgeries are not closing at this point with wave 2 and not shutting down hospitals yet, if it's going to at all again. So we're actually in an okay space when it comes to the screening and the diagnostic part, but I still have a really big job with patients to convince them that we need to do certain things. There are some things that just can't be done over a video visit or a telephone call. And I think that's one of my biggest priorities right now is ensuring the right people get the right test at the right time. And I'm really worried about some of our equity issues because there are patient populations both in the city and out that aren't even getting access to the same conversations in the way they used to before, and it was hard then. So that lens is always front of my mind.
Well, it's interesting because I saw some statistics that said that something like 87% of cancer patients are getting, for instance, their surgery in the mandated time, and that is from the time that the decision is made to have surgery to the time there is surgery. But as you mentioned, it's all the stuff beforehand. And I saw a report that said that half of all the postponed tests are CTs. That's CTs for all reasons and MRIs. So, I mean, it seems to me that it's the front part of the process that's really being backed up and people are walking around with undiagnosed cancer.
That is a worry. And the worry about it, even if they don't have cancer, there's a significant mental health impact for people being concerned about a diagnosis that even if we can refute or find is false, creates a significant burden on top of the burden of worry about COVID and families and safety. It's real.
Okay. When we come back, COVID's impact on wait times for treatment. Stay tuned.
Many cancer patients were more afraid of COVID than they were of the cancer, and that led to them canceling or rescheduling their own appointments.
Welcome back. In a recent study published in the British Medical Journal, researchers in the UK and Canada found that delaying treatment for 4 weeks can increase a patient's risk of death by about 10%. This applied for 7 types of cancer, whether the delayed treatment was surgery, radiation, or chemo. The article concluded there is no safe treatment delay. Yet throughout, we've been told that only non-urgent procedures are being postponed. So which is correct? Dr. Gill.
I would say that the access to surgery has varied, to cancer surgery has varied based on, I think, provincial jurisdiction and what the scope of the pandemic was within a region. In BC, we've been fairly fortunate that cancer surgeries have remained a priority, a treatment priority, and we have not seen delays in cancer surgery. And if anything, in fact, there was a paradoxical reduction in wait times early on when elective procedures were canceled, which allowed for greater capacity for cancer surgeries. I would also say that, when it's difficult to apply the sort of the meta-analysis that the BMJ had done, which was sort of looking at 20 years of articles that have looked at impact of treatment across different cancer types, to the context of an individual patient. So my conversations with patients often do talk about things like, what is the anticipated benefit for a cancer treatment in their particular circumstance, and what would be the impact of potentially deferring treatment. And so it is a collaborative decision, and I think each individual circumstance does require its own consideration.
Let me just clarify something. So am I correct? So when they say that your risk of death goes up by 10%, I think that means that, say, if you had a 50% chance, so it goes to 55%. It's not like it's not raw 10%, whatever that would mean anyway. Am I right?
It is a relative improvement. It's not an absolute improvement. So it is based on what the baseline expectation was. And I think it's important to recognize that people have different spectrums of anticipated treatment benefit so certainly in early stage curative settings, that time sensitivity is even more critical from a triage perspective.
Okay, Dr. Larson?
Yeah, I might also say that it completely varies according to which type of cancer we're talking about. There are definitely more indolent cancers that we feel better about waiting for, and some that are really much more aggressive. I think of the malignant hematologies, for instance, where a matter of days makes difference. And what I know about my peers and my colleagues in the cancer space, and I have the privilege of working with many of them, both as a family doctor, but also in the Canadian Partnership Against Cancer and in the Cancer Quality Council in Ontario, measuring these things. What I know is my peers are really stepping up to try to fill gaps wherever possible. That and the relationship still matters. If I'm really worried about a patient, I have people that I can phone and say, I really do need you to see Mary or John. And that often happens. So we're working really hard to try to triage the most acute and the people who need the greatest, access and the greatest time with a specialist, to make sure they get to the front of the line in a space where others may be able to wait more safely.
I'd like to bring in Annette Sear. Hi, Annette. You have a very special perspective. You are a 3-time survivor of melanoma. Wow.
Thanks. Yes, it's an ongoing challenge, and this year certainly has made it much more challenging for patients. But I also have firsthand experience, fortunately or unfortunately.
Did you experience delays? I'm sure you have lots of follow-up.
It's a strange year, actually. I was in the U.S. at the time that in March, when this outbreak was really starting to get rather serious, and we were all told to come home. And just so happened in the interim, I had some new lesions appear. So I was supposed to come home, quarantine for 2 weeks, while I was supposed to actually be in having scans done, MRIs, CT scans, and those got postponed because of the newly imposed quarantine. So, as you say, that adds a whole new dimension of stress and anxiety, wondering, going into a hospital that is now being cleared out on floors because they're anticipating handling more COVID patients instead of, in some of the cancer areas. For people that are immunocompromised already, it was a very debatable time for me do I go in and get this done? Is there delays? There was all sorts of things that were actually creating a lot more stress than I would probably just normally have from a potential recurrence of cancer.
Well, that's pretty stressful too. I hope you're okay.
I am, thank you. Yeah.
And how long were your tests postponed?
Well, approximately a month by the time we got through everything and got everything rescheduled. This was a moving target at the time as well. I mean, we have, unfortunately or unfortunately, 6 to 8 months now that we've had time to sort of adjust to what's going on, although it continues to change and worsen every day. But, at the time, we weren't really quite sure what we were dealing with and how fast it had to be executed. So, and part of it was myself. I didn't really want to go in. I was concerned that I would get exposed to something and be in a worse situation than if I delayed the diagnosis. So it was a bit of a conundrum, I have to say.
Personally, my regular follow-up screenings were postponed. It was totally no big deal, and I would have volunteered to have them postponed, but it was 3 months. And I know that for a lot of people, Conrad, that is very stressful. They just, frankly, get very upset before their screenings and between the screenings and the results.
Absolutely. Annette has very eloquently laid out the situation that many cancer patients in this country face. I wish we could say that she was the exception, but she's by no means the exception. This is an extremely common concern held by many. And over the last several weeks, the Canadian Cancer Survivor Network have been meeting with politicians and bureaucrats from across Ontario. And in those meetings, we've been joined by a number of patient advocates who have shared their stories that are very in line with a lot of the concern that Annette shares. We've talked about whether or not patients feel comfortable entering into the healthcare setting, whether that's a cancer care center, a hospital, an emergency room, and in many cases, they're not. One of the key takeaways from our COVID-19 and cancer care survey was that many cancer patients were more afraid of COVID than they were of the cancer. And that led to them canceling or rescheduling their own appointments.
Now, there's one fairly scary stat in that survey, and again, I know we have to take it in its own context, but if surgery was delayed for all breast cancer patients in Canada, it would cost 700 excess deaths in a year. So that's quite a sobering number. And when we come back, how you can ensure that your cancer treatment is on course. That's next.
There are learnings from the first wave that will be applied effectively in the second wave. So I think I would reassure cancer patients that the system has learned and we've adapted.
Welcome back. We are now in the midst of the second wave with hospitals filling up, and there is the prospect of another round of delayed treatments. What should we expect? And with all the disruptions, how can a cancer patient ensure their treatment is on course? Dr. Lael.
So my recommendation to people with cancer, I have a few. We are, sadly, cancer centers are open for business, but we're here for you. And so we're on the same side. We want your care to be uninterrupted. So please let us know. Please don't be afraid of coming to the cancer center. We have protocols. We screen at the door. We use masks. We use protective equipment, both for our patients and for ourselves. We really want to deliver the best possible cancer care. And there are teams that are working to catch up for any previous delays. CT scans and MRIs are running 24 hours, surgical teams, really prioritizing your cancer care. So we want to remind people, if you have problems, please call us. If I ask you to come in to see me, it's because I really think you need to. So please don't be shy about it. Please reach out. Please come to your appointments if they're scheduled and we really feel they're important for your cancer care.
Annette Cyr, it sounds like you understand how to take charge of your treatment. What's your advice to patients?
Well, I'd like to mirror what the doctor just said. Don't be scared. I mean, obviously, this is a very concerning environment. It's easy to say, don't be scared. There's complications. We can't bring our loved ones in with us to appointments oftentimes, but check with your hospital. Don't delay treatment. Cancer doesn't wait for COVID. So, the earlier that we get things detected and treated, the earlier and the better the outcomes will be down the road. So I would recommend people don't delay. When you have questions, consult with your physicians. I have to give them all credit and kudos because, I had exceptional care, even if there were Zoom calls and all sorts of things, they were adapting on their feet in a crazy, crazy world. So please don't delay. Make sure your health and anything of concern is brought to the attention of the professionals, and they will prioritize you. Let them do that. That's their job.
I've actually heard of people, that the doctors are diagnosing skin lesions virtually in some cases.
They are. I mean, we were very concerned at Melanoma Network. Skin cancer is the #1 cancer in the country. Melanoma is a very aggressive form of skin cancer. So our concern, obviously, when this hit was that how are people supposed to get diagnosed? GPs aren't necessarily seeing patients on a regular basis. Dermatologists, there's all sorts of steps before you even get to oncology. But what we found that there was very many dermatologists that were ramping up the virtual screenings, which, you know, that may be a new technology that we can use going forward to improve the rapidity or how quickly people get diagnosed. So I hope that continues. Maybe something good comes out of all this craziness.
Dr. Larson, so how close are we to having to start canceling what may be called an elective surgery? And we've heard that, you know, if things don't change, we're going to end up with thousands and thousands of cases a day, which will certainly postpone surgery.
Yeah, there's tremendous regionality in that conversation too, Libby. I mean, the situation in Winnipeg is very different than the situation here in Toronto or up north in Yellowknife, for instance, where they've had only 6 cases at all. So I think in the Ontario perspective, what we're doing really closely is looking at the number of people hospitalized, and then as well, how many of those are actually needing an ICU bed and how many of those are ventilated. It's a balancing act between ICU capacity for the purposes of COVID and all the other ICU cases. Car accidents don't stop happening, and issues of critical illness don't stop, and not all of them related to surgery. So we have to maintain some capacity for the regular care, while at the same time ensuring that we have space for a rise in COVID cases where possible. The good news is treatment for COVID has gotten a lot better. We are seeing rises in numbers of hospitalizations, just over 500 now in Ontario. But similarly, smaller rises than we noticed in wave 1 when it comes to ICU admissions and the ventilator. So it's really a balancing act, and what we're having to do is watch really closely. So, you know, the system itself is trying to take an integrated, coordinated approach. I'm privileged to be able to work at that system level in my work with Ontario MD and the digital space, but we are watching really closely. Right now, though, if we can flatten things, and if we can do the right thing as citizens, you know, wearing our masks, sanitizing our hands, staying 6 feet apart, it's not that hard. We can really flatten that curve and ensure we remain fairly capable of looking after the sickest and those who need it the most.
Dr. Gill, if a patient is told, okay, we're postponing whatever treatment it is, and don't worry, we think that it'll be fine to do that, you know, what should they do to make sure they're on track, or if they're not comfortable with that?
I will say that the concerns around COVID-19 are real in our cancer patients. They are often immunosuppressed on active cancer treatment. Many of our patients are elderly. And early in the first wave, there was a significant data that came out that suggested that, you know, outcomes in our patients, should they get COVID, would be worse. They would be, you know, have more severe illness, higher risk of death related to COVID. So I think the concerns related to COVID and trying to balance those risks with prioritizing treatment are valid. And in a circumstance where a patient has been advised that their treatment has been postponed, I think a discussion regarding, you know, what is the impact of that, as we heard earlier, in some situations that may be a very acceptable approach based on that particular cancer and the stage of the cancer in that case. So, you know, again, I kind of come back earlier with a frank discussion with your doctor about what is the anticipated benefit from treatment? What are my goals of care? I think this is something that's always important. And I think in the first wave, it was a big part of our conversation with patients. The system adapted very quickly to this, thankfully. And I think we're smarter in the second wave. I do anticipate that the kinds of, there are learnings from the first wave that will be applied effectively in the second wave. So I think I would reassure cancer patients that the system has learned and we've adapted.
Okay. When we come back, the anxiety around going to the hospital, especially now that you cannot have a loved one with you. That's next.
A lot of my patients will record the conversations. We certainly don't try to pressure patients to make a decision at that point in time.
Welcome Welcome back. We've been talking about the anxiety about going to the hospital for any reason amid the pandemic. Not being able to bring someone with you adds to the stress, not just because it makes people more anxious, but also because for a lot of cancer patients, it's very difficult to absorb the information they're being told by their doctors. Dr. Lail, how do you deal with that?
Thanks, Libby. It is among the most awful things during this pandemic for cancer patients. Even people who are admitted, often they can't have family members visit or have all their family members visit. So we really strongly encourage that when you come to the cancer center, if you have to come in person, that you come prepared. You've got your itinerary or your schedule, you know where you have to go. Have your iPhone with you or your iPad, make sure it's charged so we can get your loved one on the phone, on FaceTime or whatever we're going to use so that we can still converse together. Make sure that if the appointment is complicated or you don't understand everything, ask the doctors or your healthcare team to write things down for you. Increasingly, I give people a little handout saying, what we're going to do, how we're going to approach this, and so you can share it with people. Also, there's a lot of opportunity for virtual visits as well. We've really improved our technology, so it's possible to have a call with family members either at the same time or later on to really go through everything again. So please do speak up. When you come prepared, bring some sort of device so that we can connect with your family member. And again, I think we all hate this. Nobody wants to do this, but unfortunately we have to do it to stay open, to deliver quality care. And we're all looking forward to when the restrictions will end.
Conrad Eder, the old saw is that when somebody, especially when they're just diagnosed, after they hear the word cancer, they don't hear anything else.
Absolutely. It's an incredibly anxiety-provoking and time in someone's life that brings a tremendous amount of weight. What we found as part of our COVID-19 and cancer care survey is that the role of the caregiver has had to change somehow, in some way, over the course of the COVID-19 pandemic. Not being able to attend those in-person visits has obviously had a tremendous emotional impact, not only on the cancer patient themselves, but also on the caregiver who spent time being used to there in person to support them. And we applaud every effort that healthcare workers and the healthcare system have made to try to bring them there virtually. But we know, whether we're a cancer patient or we're just going to the doctor for a checkup, we know that having someone there physically with you just brings another level of comfort that being over FaceTime just can't provide.
Dr. Gill, I get all these, the talk about comfort, but what I found, especially the first time I was diagnosed, it's also a matter of the information. It's very complicated information, and depending on what the disease is, often the patient is called upon to make decisions out of that.
A lot of my patients will record the conversations. We certainly don't try to pressure patients to make a decision at that point in time, using follow-up virtual visits or phone calls to kind of help them absorb the information. I think we do have to adapt accordingly.
And you miss the physical interaction.
So much about medicine is about our engagement with our patients, our relationships with our patients, being able to hold a patient's hand or give a patient a hug. And it brings tears to my eyes to now think about situations where I haven't been able to do that, or I've had to say goodbye to patients over the phone.
Now you're bringing tears to my eyes. That's terrible.
Yeah. I will say that I also wear a hat as an executive member of the Canadian Association of Medical Oncologists, and we have tried to reach out to our membership to see how medical oncologists, how care providers are coping with this. And I think, the moral distress of the pandemic and what we see our patients going through weighs heavily on the entire cancer team, our oncologists, our nurses, our surgeons. But the resolve to help patients get through this, it's just been remarkable. I'm so impressed by the people I work with.
Annette Cyr, what do you tell patients, and again, what is the impact of seeing their doctor, gowned? On television, we've all seen cases of where doctors, they wear a name tag. You can't tell who it is.
Yeah, it's, having firsthand experience, of course, I know them, so it's not as bad. But for first time people going through this system, it just adds more layers of anxiety. We're certainly seeing it at our organization. Our calls to our support line for mental health issues and the additional stress that caregivers are going through. There's a lot of organizations that are providing, mental health supports. The hospitals are trying their best to provide as much access to those, social workers on staff and such as well. So if you're feeling that additional stress, that lack of connectivity that we all kind of are feeling at this point in time, we have to try that much more to reach out and connect with our loved ones, connect with people going through treatment, to let them know that we're there. It's in a different way, but we're adapting. And like you say, you can't give us a virtual hug, and we appreciate that, but hopefully other people can do that in the interim.
Dr. Larson, I know that hospitals usually offer a kind of wellness support, mental health support. Are those working just as well virtually? I'm thinking of things like, I think it's called Wellness Garden, but there's all kinds of support.
There is a lot of support. And in fact, some of those modalities work really well virtually, particularly in the mental health area where it's a talking kind of situation. And it's actually improving access to a certain degree where you don't have to pay for parking and you don't have to take a day off work to meet with your social worker, your psychologist. But I also want to put a big plug in for the family doctors like me out there who have really long-term relationship with our patients. Like, we're really there to help you do some of the interpretation of what you're hearing and what those results look like. And when Dr. Lael finishes her report and dictates it into her system at UHN, it's in my EMR inbox within 15 minutes. I get that data almost immediately. So I encourage patients to certainly speak to their primary care provider and use this as that bridge, because it's really what we're here for.
Okay, we'll have more on remote support for cancer patients. That's next after the break.
A significant proportion of our virtual visits are still telephone. Not all patients are proficient with the use of video technologies and Zoom, and in many cases, it's much more practical.
We at the Canadian Cancer Society have had to innovate. So the programs and services that took place previously in person, we've had to transition to an online environment. So things such as our breast and wig prosthesis banks, we've actually moved to an online environment now, whereas previously it was an in-person service that we provided. And we're also really trying to encourage people to access support through our online platforms, such as cancerconnection.ca, where people can go online and speak to others who are having a lived experience with cancer, whether as a patient or as a caregiver. And then we heard about their concerns about talking to their doctors and reaching health professionals. And we've heard a lot from people who are wanting access to practical services. We're talking to people every day about how they can maximize their appointments with their physicians and their cancer treatment teams. And also to reach out to communities of people like cancerconnection.ca, where they can actually speak to others and problem solve together about how they've been able to remain connected to both their loved ones and their family members and friends locally, but in a safe way, and also make these new connections virtually.
As we just saw, support groups like the Canadian Cancer Society have ramped up their virtual activities during COVID. Doctors have too. Oncologists are conducting real-time video for consultations and monitoring patients after they're released from hospital. Actually, moving to more virtual care was already in the works before COVID struck. So what has been available for patients? Dr. Lael.
So, as you said, COVID has been good for our ability to deliver virtual care. So increasingly, we're able to do video discussions. We're also, really trying to improve our ability to give, digital information prescriptions, we call them, where we can get you information and go through it with you the same way we used to do it when when a person came into the cancer center to see us, so that a nurse can be with you on the phone or on video and actually review all those same handouts that we actually just email you through this particular program. And so, we've been working on that. We've also been working on different initiatives. For example, unfortunately, some of our cancer patients do get COVID. Not everyone needs to be admitted, and there's a lot of fear, if you don't need to be admitted and maybe you're not receiving treatment treatment, people are really afraid of this. And, what do I do if I get sick? So we've actually developed a COVID care clinic where it's a nurse-run clinic where a nurse will call you every day. It's a specialized cancer nurse, and she or he will phone all of our patients with COVID to make sure that they're doing okay, that they don't have any questions about their cancer care, monitor symptoms, and make sure that they don't need more urgent help. So we're really making progress in terms of what we can do virtually and online.
I think also when it comes to follow-up appointments, I remember about exactly a year ago, I saw a very interesting presentation from someone also who was at Princess Margaret. And they were coming up with a model where, there are some in-person appointments that you don't actually need, where the patient would get to choose if they come to an in-person appointment or not. And frankly, there are some times for patients, when the last thing you want to do is have to get dressed, drive, park, and all of that for, a short consultation.
Absolutely. And I think we're seeing more and more use of this. But again, we need to be careful. Not everyone is so well that a virtual visit is enough. So really important to let us know if things change or you're not as well as you were last week when we spoke on the phone, for example. And I think the other interesting thing that we've been doing increasingly is we're now able to collect your symptoms and how you're feeling. You can do that at home on the internet. And then we actually get that feedback. So we also know what to ask for and sort of, what some of the issues are with you, even before we have our call.
Okay, and Dr. Gill, Dr. Lael was mentioning a very old-fashioned device, a telephone. So does that play a role in remote care?
Yeah, a significant proportion of our virtual visits are still telephone. Not all patients are proficient with the use of video technologies and Zoom. And in many cases, it's much more practical because patients, especially well patients who are on follow-up, may be on the go. And, we've talked about virtual medicine as perhaps one of the silver linings we'll look back on with this pandemic. And it is something that, as you said, pre-COVID, we have often talked about moving towards, and then that change was forced upon us. And many patients have welcomed it. But I agree fully with Dr. Lael that we have to be judicious about how we use virtual care. It's certainly appropriate in circumstances where patients are well for follow-up visits, but for many patients on active treatment, those often still require in-person assessments.
Dr. Larson, I know that a lot of GPs are basically not doing in-person visits.
Yeah, it's really switching. During the early days of COVID, I quote this 7 to 91 phenomenon, which happened within 2 weeks of COVID. We went from about 7% virtual care use to 91% in primary care, and 80% of our visits were being done virtually, meaning 91% of us were using virtual care tools for 80% of the visits. Now that's shifted back again as things have stabilized and we're doing far more in person. But right now in my own clinic, I'm seeing it's about a 60-40 split. 40% of the visits are required to be in person because you just have to do something or examine something. 60% can be happened through a virtual modality. And I'm using email, text messaging with my patients. I'm using secure video conferencing built into my EMR, and I'm also using the telephone quite a bit. So for me, virtual care is just care. We need to offer the right care for the right patient, the right time, and the right problem. And we need to select better upfront in how to do that so that we're not having to force them into a modality they don't belong, or the problem doesn't belong, or we don't have to see them again or 2 or 3 times to get the right service. So we're getting better at that triage concept too, and making sure we're offering the right visit and asking them, frankly, if it works for them.
And I'm just curious, if times were normal, what do you think the right breakdown would be?
Yeah, if you look at systems like Kaiser Permanente in the States and some parts of the NHS and in Sweden where they've been doing virtual for a long time, it seems to be about a 60-40 or a 55-45 split in primary care. It won't be the same for many of the specialties that do require a lot more sort of advanced diagnostics or hands-on work. Like a surgeon often has a really hard time with his initial visit without an examination, but an endocrinologist, for instance, can order all kinds of blood work on you and get those results almost in real time and have a visit with you over a telephone or video conference quite easily. So it really is specialty specific.
Okay. When we come back, we'll hear some final thoughts from our panelists. Welcome back. Now our panelists will leave you with some final thoughts, starting with Dr. Gill.
Thank you, Libby. I think I would just remind patients with cancer that we are in this together. We are all in this together. We've heard from our panelists that cancer does not wait. And through the pandemic, I would want people to have confidence that cancer systems across Canada have adapted, have put protections in place so people are safe. And, this is, we will get through this.
Dr. Leal.
I want to echo Dr. Gill's comments and also just remind people, we're here for you. If you think something has been overlooked or you're wondering if you should show up for an appointment or a test, please call us. Please let us know. Also, so important to let us know if things change with how you're feeling. Please don't be afraid to come to the cancer centers if you need our help.
Dr. Larson.
I was going to say much of what they said, but cancer to me, from the journey of first suspicion to diagnosis and treatment and hopefully cure, is in fact a team sport. The oncologists are there for you, your surgeons, your nurse specialists, and your family doctors, nurse practitioners. We're in this together with you. So whatever it takes to make you feel like you're getting the care that you need and to get the advocacy sometimes where you feel like you're not, please use any one of us, because we do try as much as possible to work together.
Conrad.
I think it's important that cancer patients across the country realize that their voices are incredibly important. And that's emphasized by the incredible work that we've done across the country with our COVID-19 and cancer care survey. We all know that cancer can't wait, and cancer patients, caregivers, and pre-diagnosis patients across the country should be reassured that at the Canadian Cancer Survivor Network, we're going to continue to advocate for them, ensuring that they have safe, timely access to cancer care, even amid a public health emergency.
Annette Sear.
And I'll reiterate what Conrad said. I mean, there's patient organizations, use the tools that are available to you. Have your caregiver help support you, reach out. There's such urgency to get these things looked at, and the outcomes are more positive if you get things dealt with early. Absolutely.
The pandemic has hit cancer patients and the cancer system hard. Our healthcare system is responding, but it's also up to you. We hope the advice you have heard here will help you take charge of your treatment and stay on track for the best possible outcome. Thank you to the panel for joining us and to the audience at home for watching. Be well and stay safe. It's time to zoom out.